Hello and welcome. My name is Elizabeth Wade, and I have shared a short summary of my professional background at the end of these slides. The title of this presentation is Multiple Risk Reduction Strategies, Case Study Number 2. This is the relevant financial relationship disclosure for this presentation. This is the learning objective that will be addressed during this presentation. These are the key abbreviations that will be used during this presentation. Remember, for the practice exercises, the goal is to review the case, identify factors that contributed to the medication error, and for each given error, provide an example of each type of risk reduction strategy tool. For each risk reduction strategy example, we're going to identify a principle and any unintended consequences that you can think of. To understand about this medication error and its context, I'm going to give you some background on the organization. This is an error that occurred with the take-home prescription process from the emergency department. In the ED in this organization, they use paper medication orders. Medication orders are sent to a pharmacist if the medication needs to be prepared by the pharmacy. For take-home prescriptions, what's supposed to happen is these are used for dispensing emergency supplies of medications. There are pre-printed order forms that the ED providers use to order the prescriptions. The medications are available in an automated dispensing cabinet. The medications are already pre-packaged and have pre-attached labels with blanks on them for patient information and instructions to be completed by ED staff. The ED nurse is expected to fill in the medication label information, and the ED provider is supposed to check the label and dispense the medication to the patient. The patient signs for the medication on receipt, and the ED staff provide any necessary counseling for the patient to take the medication safely. Now let's talk about the case. In this case, a patient was a 4-year-old female who presented to the ED with acute head injury and right ear laceration. The ED provider planned to order a 5-day course of amoxicillin clavulanate suspension. In the ED note, the provider documents thinking about amoxicillin clavulanate 250 milligram per 5 mLs for 5 days. Now pay attention to that concentration because that's going to be the key to this case. The ED provider completed the pre-printed order form. On the pre-printed order form, pediatric antibiotics include amoxicillin clavulanate. However, the concentration on the order form is for 600 milligram per 5 ml suspension to match what's provided in the automated dispensing cabinet. The provider completed this order form with a dose of 2.5 mLs every 12 hours. Unfortunately, when the provider filled out the pre-printed order form, the provider completed the volume in the dose field that was intended for the 250 milligram per 5 ml concentration. The nurse, when completing the ED label on this pre-printed label that came from the automated dispensing cabinet, the nurse used that same volume to fill in the directions here for the patient. Here is an image of the amoxicillin clavulanate product with the pre-printed label for the nurse to complete. In this particular case, the nurse did not complete the label to the full extent. The nurse left the directions for give blank mLs by mouth every blank hours blank without filling in the dose and the frequency. The nurse documented the dispensing of the Augmentin here on the medication administration record. You can see that the dose documented as being given is 2.5 milliliters without a specific concentration documented in the medication line. The patient discharge instructions showed Augmentin 250 milligram per 5 ml. In the discharge instructions, the provider directed the patient to take 1 teaspoonful or 5 milliliters by mouth 2 times per day. This is different than the directions that were written in the ED note and the dose that was documented on the medication administration record. The mother of the patient did administer 1 5 ml dose to the patient before discovering that the bottle in her hand was actually a different concentration than the prescriptions written on the discharge instructions. Fortunately, the mother was very astute and caught this error early on, and the child did not suffer any untoward effects. But let's take a look at the medication use process steps for this case. First, the provider intended to order amoxicillin clavulanate 250 mg per 5 ml suspension. After that, the provider completed a pre-printed order form that included amoxicillin clavulanate 600 mg per 5 ml suspension. The amoxicillin clavulanate 600 per 5 suspension directly was dispensed from the automated dispensing cabinet by the nurse. The nurse did not complete the instructions on the suspension label. And finally, the ED provider included discharge instructions for amoxicillin clavulanate 250 mg per 5 ml suspension for 5 milliliters twice a day, rather than 2.5 milliliters twice a day before as planned. Just like a lot of cases, there's a lot of contributing factors to think about. For this case, the ED provider did not know what concentrations were available for the take-home prescription program when generating the ED note and patient plan. When the provider completed the pre-printed order form, there was a knowledge deficit of the dose and the ordered concentration available on the form. The provider then forgot to go back and update the prescription information in the patient discharge instructions. There was a lot of information documented about this medication concentration and dose in a lot of different locations that needed to be manually updated. The ED nurse who removed the medication from the dispensing cabinet was rushed and forgot to complete the label. The nurse counseled the patient using the patient discharge instructions document, and the provider who dispensed the medication did not notice that the label was blank. Thankfully, in this case, the patient's parent was a healthcare worker. So while that was a good thing, and that's probably why they caught the error, there was also some confirmation bias that that parent knew what they were doing, so they didn't need to provide as much instruction and counseling for the patient. So for this case analysis, we're going to address two errors. The first error is that the incorrect amoxicillin clavulanate concentration was selected from all the available options in the ED documentation system when generating the therapeutic plan. The ED documentation system that generated the ED note and discharge instructions is a separate system from that pre-printed paper order, which is also a separate system from the automated dispensing cabinet. Ultimately, the disparate systems in the ED for ordering and dispensing medications contributed to this error. We can also look at the second error, in which the nurse forgot to update the label with patient instructions, which was also missed by the provider when handing the medication to the patient. A contributor to this were distractions and time constraints, with both staff members feeling rushed. The cause was that completing the label relies on human vigilance in order to be done. Now it's time to review the case, the contributing factors, and for each given error that we talked about, provide an example of each type of risk reduction strategy. For each risk reduction strategy tool example that you come up with, please also identify the risk reduction principle and any unintended consequences. As a helpful refresher and reminder, here is the risk reduction tool list, adapted from ISMP's Hierarchy of Effectiveness. Here is a reminder of the risk reduction principles. Now go ahead and complete the worksheet. Remember that the worksheet is broken down by the risk reduction tool in the left-hand column. For each risk reduction tool, you're to provide an example, outline the principle, and share any unintended consequences. An example of a forcing function for this case would be barcode medication administration verification of any meds dispensed for take-home from the ED. This would validate that the product being dispensed for take-home matches what is ordered, including the concentration. This would make the error more visible. Unintended consequences of this are high cost, resources and difficulty of implementation, and the need to adapt to workflow changes, especially for a fast-paced environment like the ED. For barriers and fail-safes, we might be able to remove medications for take-home completely from the ED, and they have to all be dispensed by the pharmacy with patient-specific labels containing appropriate patient instructions. This would certainly reduce the likelihood of the error. However, this would significantly increase pharmacy workload, especially on demand in the middle of the night with fewer resources, and this would be a delay in patient care if the patient now has to wait for the take-home prescription to come from the pharmacy. For automation and computerization, we could implement computerized provider order entry in the ED. This would certainly reduce the likelihood of the error. This could interface with systems in the pharmacy, such as our automated dispensing cabinet. Unintended consequences of this, like all of the other high leverage strategies, are high cost, difficulty of implementation and resources, and workflow changes. For standardization and protocols, we could standardize the concentrations that are available for medications that do have multiple concentrations in the ED documentation system. We can make sure that the concentrations match in the ED documentation system, the pre-printed paper orders, and the automated dispensing cabinet. In this case, we only had a match of 2 out of the 3, and the ED documentation system had a different concentration. By matching all 3, we can reduce the likelihood of the error. However, an unintended consequence could be limiting the therapeutic options that ED prescribers can choose from when they're prescribing to outside pharmacies. There are 2 opportunities to introduce redundancies into this process. The first one is having a pharmacist check products prior to dispensing them to the ED. This could certainly reduce the likelihood of the error, but again, increase pharmacy workload and potentially introduce delays to the process. We could also introduce an independent double check of the product and label by ED staff prior to dispensing of any emergency supply of medications. Again, helpful in reducing the error, but increase emergency department workload and also potential delay to patient care if it's difficult to find a second staff member to check with. For warnings, alerts, reminders, and checklists, we could place an indicator on the amoxicillin clavulanate suspension concentrations that are available for ED emergency supply dispensing. This visual indicator would help reduce the likelihood that an incorrect concentration is selected. This would take some more informatics resources and require maintenance to keep up with what's available in the dispensing cabinet. Another way we could introduce an alert or reminder is to place an alert on medications in the automated dispensing cabinet for the nurse to complete the patient label in full. This could reduce the likelihood of the error, but an unintended consequence are alert fatigue, as well as the fact that this alert might not be well timed. The ED nurse could very well read and pay attention to the alert, but then later forget to complete the label. In this particular case example, the organization already had a policy and procedure regarding the dispensing of the emergency supply of medications. In this case, it was meant to reduce the likelihood of the error, but was a low leverage strategy. As you can see, unfortunately in this case, the policy was not followed. Finally, it never hurts to conduct education. We can conduct staff education for the emergency department regarding checking concentrations and completing patient labels in full. This would help reduce the likelihood of the error, and in the short term, staff may really pay extra attention to this process. But again, this is going to be low leverage and not long lasting. With all of these options, what did we decide to do? Well, again, like case number 1, we had to come up with short-term, intermediate term, and long-term solutions. In the short term, we standardized the concentrations available for medications with multiple concentrations in all 3 locations, in the ED documentation system, on the pre-printed paper order, and in the automated dispensing cabinet. We also conducted staff education and implemented a policy. For the second phase, more intermediate, we were able to work with our informatics team to place an indicator on the amoxicillin clavulanate concentrations that were available for ED emergency supply dispensing in the ED system itself. This visual cue was helpful for providers to know what to pick. We were also able to place an alert on medications in the automated dispensing cabinet as a generic reminder for nurses to just complete the patient label. In the long term, and again, many years later, we eventually implemented computerized provider order entry in the emergency department and implemented barcode medication administration verifications of medications in the ED. And in concert with CPOE, we were able to validate that medications being dispensed matched the product ordered in the order entry system. In conclusion, when we evaluate medication error events in an effort to reduce risk and prevent similar errors in the future, for each risk reduction strategy, we need to consider the leverage and strength of the strategy, aiming for high leverage strategies whenever possible. We need to consider a combination of strategies and think about unintended consequences that might occur as a result of those higher leverage strategies. Finally, Not all solutions can be implemented right away, especially the high leverage ones. So think about the feasibility of implementation in the organization. And if it's not feasible to implement the highest leverage right away, it's okay to develop a short-term, intermediate-term, and long-term plan. Thank you very much for your time and participation.